Maddie, we are beginning. Tonight, you're going to learn about chest trauma. There will be a lot of questions on exam 3 about chest trauma. Thoughts for the day: everything you do is going to be photographed and videoed. It is not uncommon to be on scene, especially out in public, of a car wreck or something, or a person hit by a car, or sucked into the propeller of a tractor, and there's 5 or 6 different cell phones filming you live. Get used to it. Make sure that your words, actions, and choices are what you want to be on the internet of you for the rest of your life and career, because it will never go away. So make sure that you are professional at all times. Any questions? We're going to go to the difference between blunt and penetrating chest trauma. We're going to go over the signs and symptoms of a pneumothorax, a hemothorax, an open pneumo, a simple pneumo, an attention pneumothorax. And we're going to learn about what a cardiac tamponade is and the signs and symptoms. Then we're going to go over the signs and symptoms of rib fractures, flail chest, commota cordis, pulmonary contusions, cardiac contusions, and lacerations of the great vessels that we've been learning about since day 1. And we're going to go over the appropriate treatment for each one of those. You're going to need to know the signs and symptoms of all of these conditions, what they are and how to treat them, or you will not pass exam 3. Any questions? Or the midterm? There's the organs of the chest. They're extremely important to survive. Your heart and your lungs, and your great vessels, your inferior vena cava, and your superior vena cava, your pulmonary vein, and your aortic arch, which breaks out your brachial and your carotids, and your descending aorta. Any questions so far? That's the rib cage of your chest, the sternum, each one of your anterior ribs, the xiphoid process, the angle of Lewis. Any questions? So we've been over this at least 2 or 3 times, so we're going to go over it again because it's important that you know it and understand it. Inspiration: your diaphragm and your intercostal muscles contract. It creates a cavity inside your thoracic cavity. Creates more space inside your thoracic cavity, which makes it less than atmospheric pressure. Atmospheric air rushes in. Then your diaphragm and your intercostal muscles relax. That creates greater than atmospheric pressure. The air rushes out. Any questions on how you breathe? Mechanics of ventilation. Because when these things get broken, it's very hard to breathe. So, remember those vertebrae we talked about? You got to know each one of their names. So 3C and C3, C4, and C5. You're going to lose the ability to breathe. You're not going to be able to run your diaphragm or your intercostal muscles. If it's C4 or C5, you'll lose the intercostal muscles, but you'll still have your diaphragm. So you'll still be able to breathe on your own. If it's C3 or higher, you're not going to breathe on your own. Someone better ventilate you immediately. Any questions? And you'll be on a ventilator the rest of your life. Yes.
So you're saying that the phrenic nerve controls the diaphragm?
Below C3. If your fractures, if you lose the spinal cord at C3 or above, you will not be able to control your diaphragm. C1, C2, C3, you're done. Well, not always. There was a guy, famous actor Christopher Reeves, he was Superman back in the 70s, 80s, and he broke C2, complete fracture, severed C2. But they saved him. They were able to ventilate him. He had an equestrian accident. And he spent the rest of his life on a ventilator. So not a great quality of life. Anybody know what the horse's name was? Kryptonite will be on the test. The duck drive. All right. Any questions? All right. Blunt trauma to the chest. Closed injuries are blunt trauma. Open injuries are caused by penetrating trauma. Any questions? Look at that. That's called getting stabbed in the back. Anything between the jaw and the navel, we put with that dressing on. But this is on the back, not the chest. Doesn't matter. Any questions? If it is on the thorax, though, you want to leave one side up or one side not taped down so it works as a flutter valve so air can escape but can't get sucked back in. Or use a commercial one-way valve like a Hyphen or a, I can't think of the name of the other one. All right, pneumothorax. The layman's term for a pneumothorax is a collapsed lung. So simple pneumothorax you can pretty much deal with. It's just full amount of air, really partially collapses the lung. You'll be uncomfortable. You won't be able to lay down. When you lay down, you won't be able to breathe. As long as you sit up and you breathe fast, you'll still be able to breathe. However, an open pneumothorax is when you have a hole that penetrates into the pleural cavity. So it doesn't matter if your diaphragm contraction or intercostal contraction, you don't have a seal. So basically air is rushing in and out. So the atmospheric air, you can't get that negative pressure. That's a big problem. And then a tension pneumothorax is when every time you breathe, it puts more air and it crushes the lung even more and eventually starts crushing the lung and the great vessels. So then you lose the ability to exchange gas, oxygen, carbon dioxide, and you lose the ability to flow blood. Tension pneumothoraxes are 100% fatal if not treated. Unfortunately, as EMTs, you do not have anything in your scope of practice that you can treat them with, so you need to get them moving as quickly as possible to someone who can. Paramedics can dart the chest. They can take a 14 gauge needle, pop it like a balloon. Any questions? Yes.
What happens when it's just blunt trauma?
What's that?
What happens when it's just blunt trauma?
Well, blood trauma can still cause a pneumothorax. As you break a rib, the rib punctures a hole in the lung, and every time you breathe, it lets air out in the pleural sac, and then it starts crushing itself. Penetrating trauma can cause an open pneumothorax, which then you don't have the negative pressure, so you can't breathe because you're not getting that atmospheric air rushing in and out. There's a great picture of an pneumothorax. So you got the hole in the lung, so it's letting air out in the pleural space. So every time you take a breath, it crushes your lung a little bit more till it kills you, or until someone takes a needle, puts a hole in the one-way valve, and lets the air escape, then not back in. That's also the reason why on penetrating trauma of the chest, you don't want to seal all four sides because you can create a tension pneumothorax. Any questions? You got to let that air escape, but not come back in.
So that would mean that they go before get into the ER, which is the break.
Well, for an open, you guys can do that. You just put a chest seal on it, leave one side open. If it's closed and a tension pneumothorax, you got to get them to the ER, get them to an ALS rendezvous, or they're going to die. And whatever you do, don't wait on seeing for a helicopter or a paramedic to get there. Just start moving. Have them meet you somewhere in between. So simple pneumothoraxes is usually from blunt chest trauma. Often isn't even detected in the field because it's so hard to detect. Common signs symptoms are dyspnea, elevated respirations. They really don't like to lay flat because it increases their dyspnea. But generally, most people in the field, you can't even tell by the lung sounds are still clear and equal. It's really, really hard to tell unless you're extremely good at lung sounds. You're probably not going to catch that. What you are going to catch though is they've had blunt trauma to the chest, elevated respirations, and they really will not lay flat. That'll give you an indication they probably have a simple pneumothorax. Concern with simple pneumothoraxes is they won't kill them, but they can develop into tension pneumothoraxes. So time is still of the essence. Any questions about simple pneumothoraxes? All right. Open pneumothoraxes. Sometimes you get a whistling sound because they're trying to breathe. Any questions? Pretty good drawing. That's not compatible with life. Any questions? Yeah, we know. Yes, we're all adults.
We didn't find anything on.
You got bit by a pit bull, her dad got freaked out to get up, but she stabbed up a fucking chest wound here. Her chest X-ray actually looked pretty good, but
That's pretty crappy look, Trev.
had a bunch of
I expect better.
lacerations here in the leg.
Oh.
I'm sorry, big girl.
You're not gonna touch it. You're just gonna show them, okay? I'm gonna fix it so we're gonna turn it on, okay? Do they turn it on?
Alright, you saw what it looks like. So this is fake, it's Hollywood, but it's some of the best animation I've ever seen. For realistic of what a pleural decompression looks like. So if you have a tension pneumothorax and someone can get a needle in and decompress, the organs will actually reinflate. And this is pretty good animation of it.
Hey, you made the right choice today, Conrad. You stop with that shrine shit. Everything's gonna be okay.
Thanks, Dad.
I know so. Get out of here. Hey, Yanka! Would you please fucking help? God damn it! Ah!
What?
Pretty good animation of crushing the lung and the arteries.
Air of his chest is crushing his lung.
Nice PSI. Hollywood. Lung reinflates. Let's take the air pressure off.
I feel better.
Alright, so treatment for an open pneumo, put an occlusive dressing over it, leave one side open for a flutter valve. Or use a high fin seal. If you completely seal it, it will almost definitely become a tension pneumothorax, which will be fatal. 100% of the time. Any questions? good drawing of what happens if you completely seal open pneumothorax. It'll quickly crush the entire chest internally. Don't do that. Any questions? The signs, symptoms of attention pneumothorax. This will be on the test. They'll have respiratory distress. So the lungs crushing the great vessels and the heart, blood's going to back up into the vena cavas, into the inferior and superior vena cava. When it backs up to the superior vena cava, it's going to engorge the jugular veins because the jugular veins drain into the vena cava. So it's going to back up like a traffic jam. You're going to see big, thick jugular veins called jugular vein distension, JVD. In late signs, right before they die, they'll be sucking air so hard on the good lung, it'll actually deviate their trachea towards the good lung, away from the affected side. They're going to be tachycardic. They're going to have low blood pressure because the heart's not able to expand. There's no blood pressure going through it because the heart can't pump because it's being crushed. The pneumatic vice. Cyanosis, they're going to turn blue. And you're going to have decreased lung sounds on the affected side. So the big thing is respiratory distress, JVD, tachycardia, hypotension, and decreased breath sounds on one side with blunt chest trauma or penetrating. You should be thinking tension pneumothorax. You're going to get test questions that are going to present to you. A guy has been ejected from a vehicle or hit by a car or hit in the pipe with a chest or stabbed in the chest. He's got a respiratory rate of 40. He's got jugular vein distension, a heart rate of 136, blood pressure of 70/30, and decrease in absent lung sounds on one side. What do you think's wrong with this patient? It's going to ask you. Tension pneumothorax, pericardial tamponade, hemothorax, pulmonary contusion. You're going to have to figure out which one closely aligns with those signs and symptoms. These are the signs and symptoms of a tension pneumothorax. Any questions?
Zaprezentujemy, jak pracują zdrowe płuca, cały proces wentylacji i oddychania.
This one, they lacerated the
Tkanka
lung.
zdrowa,
They're
nieuszkodzona.
going to cover it up in a trash bag. Show you guys like a plural section of how
Wygląda
tension
sytuacja, kiedy
pneumothorax
mamy
develops.
szczelnie na klatce piersiową i płuca pracują w klatce piersiowej.
That's what it should look like when you're breathing.
Okay. Drugi preparat został pewną.
Now they're going to show you a lacerated lung and what it does.
Jak zaprezentujemy
The laceration of the lung.
ciśnieniowy uraz od eksplozji. Tkanka jest uszkodzona i powietrze ucieka. Teraz zaprezentujemy, jak to działa w sytuacji.
The pressure builds up in there. That's what a tension pneumothorax is.
Teraz ponad płucu. Otwarczenie.
Any questions? Yeah.
So a simple pneumothorax is just when there's air between.
Yeah, it's just a small pocket of air. It's starting to crush the lung, but not really bad.
Okay, gotcha. And that could be from a puncture in the lung or just.
It's usually from a puncture in the lung, yes.
Okay, so we'll almost always develop tension pneumothorax.
Maybe, maybe not. Just depends. Sometimes it'll tamponade itself off. The air pressure will cover that little hole, like it's just a small hole.
Okay,
And sometimes the whole clot, if it's bleeding by it, the clot will actually solve it.
okay.
But they still won't let you lay them down because they're not getting full lung expansion.
Yeah.
So again, if you've sealed an open pneumothorax and you start seeing any signs and symptoms of tension pneumothorax, make sure you unseal one side and one corner so you can let the air out. If that's not the case, you got to get them. Nothing else matters. You have to get them to somewhere that can decompress it. Any questions? Because they will die. So this is what a pleural decompression looks like. This is a guy, I believe, in Georgia, the country, not Georgia, the United States, who actually put a thoracoscope in and videoed a tension pneumothorax and then the decompression and watching the lung area inflate. It's kind of cool. And the person's alive because all this tissue's pink. It's not a cadaver. I hate people.
Military, the unknown age to fail, shot multiple times.
This apparently is my replacement.
It's gotta be somewhere right in this area.
They cannot pull up, there's a lot of.
It's actually
police
real.
everywhere and already set up paid.
There you can.
Thank you. 29, 14, 28.
away. Are you sure? As soon as I get next to the guy, his lips and face are just blue. He looked dead.
I got one in the right chest.
He's got one wound right to the chest, and immediately you think collapse lung or chest full of blood. Lori, when we get him in a truck, pop him in the chest. When I heard him talk, let's go next, I was like, we need to move. If this guy has a chest cavity full of blood and it is not corrected and corrected soon, it will kill him. I don't know if there's any place else.
All right, you guys see that? You can actually see some chest will bubble.
If this guy has a chest cavity full of blood and it is not corrected
You
and
actually see
corrected
it bubble
soon,
when he's
it will
breathing.
kill him.
That's the classic second chest wound.
There's any place else.
No problem, breathe.
We'll get a call from male shot,
Why is it?
probably because his cavity's filling over blood.
It's long time.
Won't be for long. His cavity is actually filled over blood to the point where it's causing a collapse of the lung, which can be life threatening. I will. So we'll have to put a needle through the ribs into the cavity to relieve pressure. He had instant relief, which was good. I mean, that's what we do it for. Unfortunately, you know, it's not gonna last very long. We bought him like 5 minutes, now we gotta go.
All right, let's go.
Yep.
All right.
Hey, babe, you still with me? Hey, you still with me? Thank you. We got you, baby. We're going to the hospital right now. This guy was so terrible. I can tell just by looking at him, he is not getting oxygen. Definitely gonna be You're gonna be all right, baby. We're gonna take care of you. He's losing the battle. So I need to push him to fight. Do you know who did that to you? Did they try to rob you? Talking to him constantly, like, hey, talk to me. Don't go to sleep. Hey, baby, what's your name? Hey, what's your name? Talk to me. I need to know that you're still awake. Okay. You're gonna be all right. I just need you to not still up, okay? When you have a patient like this that, you know what's wrong, you know what they need, you just don't have the tools and the capacity to do it, and you're only a few minutes away from the people who can, you want them to understand that and you want them to fight because they definitely have a chance at surviving and you know it. You still with me, sweetie? All right, good. We're pulling him to the hospital now, okay? As hard as that must have been, he stayed awake the whole time. I'm gonna tell you what, that is a will to hold on. That dude had 650 cc's of blood.
So you have what's called a hemothorax. That's where you get blood inside the chest cavity instead of air. It was actually a hemopneumo. So this one, you get done with the stupid ads. This one's pretty impressive. So this is a guy that got shot in combat. They actually had to dart it twice, bilateral tension pneumos.
The sweet always comes first. His sweep reveals no other injuries, but he's in critical condition. The gunshot wound has trapped air in his chest, crushing his lungs. It's up to the rookie to save him. Barry raised a chest dart, a needle inserted into the torso to relieve pressure. If Barry misses the mark, he might hit an artery, a fatal mistake. Zen, but he's still struggling to breathe. Send back. The soldier is suffocating. Matt readies a second target. The soldier can finally breathe.
That's darted twice. Any questions? Yes.
So is that within our scope of practice or no?
No, you guys can't do darts. You gotta give it to somebody you can.
Oh, why didn't the first start work?
I think, yeah, he darted the other side of the chest, so it was on one side, you could relieve that side, be a double pneumos. So he'd dart the other side. So hemothorax, when you get blood instead of air in the pleural space, if you get blood in air, it's called the hemopneumo. So hemothorax cannot be tension though, but it's still gonna definitely compromise them and can still kill them. It's not quite as quickly as a tension pneumo.
So if you have a heme on your mouth and you start them, it'll still like provide them with some kind of.
You absolutely relief. Because it's gonna take the air pressure off, so it's just blood in there.
Okay.
So it'll still be compressed, but not as compressed.
Gotcha.
And what they're gonna do as soon as they get to the hospital, the first thing the surgeon's gonna do is put a hole in the side of the chest, put a chest tube in, and drain the blood straight out. So there's a hemothorax, there's a hemopneumo, make sense? Here's some pictures of, or some videos of them actually doing that.
Un espacio costal abajo para hacer un túnel y nuestro corte es un espacio costal
What
abajo.
they'll do at the trauma field is they'll cut the side of the chest open, stick their finger in,
Dolor,
and put a chest tube in and drain the blood out.
ninguno. Perfecto. Hay que meter. Aquí entré, meto mi dedo hacia el
This is
interior
not your scope practice either.
y ya siento la pleura y esto.
I think, Charlie was a little bit better. So this was actually a thoracotomy. This is where, they actually split the chest in the ER. And, go in and try to do the repair immediately. And they actually had to do internal compressions of the heart. We actually had a student in this class once got to do that. Brought in a great vessel laceration. The aorta was lacerated and guy went into full arrest right as the crew pulled in. And the trauma surgeon split the chest right there in the ER and he sewed the aorta back together. And then she was still cardiac, guy was still cardiac arrest. So he grabbed the EMT student's hand and put it in the chest and showed her how to do internal cardiac compressions. And she got to do it until they injected epinephrine and shocked it. Then the heart started beating again right in her hand. It was pretty cool.
And this class?
Yeah,
How long ago was that?
a long time ago, about 20 years ago. Yeah, she was actually ADJ major law enforcement. She went into nursing after that. It was pretty cool. We don't have vascular surgeons here anymore. That was back when we had vascular surgeons that could do stuff like that. We don't have that here anymore.
Basically, just bam, all the way down to the shoulder blade. The shoulder like all the way down. You got hands, hands over.
Has it, has the script writers?
Work on the thread. It's 400 thread, let's go. How much? The bottom left. Where in the lens? Where is it?
Pull the tube out. Here, pull the tube out, yeah. You're right. I know, but if you don't have space.
Let's not pull it, we're getting, I'm taking. No, what do you take? What do you take?
That's the wrong way. Go ahead.
Yeah, but you don't take.
Clean out the right chest. Well, then, you go ahead. It's like.
Take Red's head.
You got the big clamp? You got the big clamp?
Right there. Take
Take it on across. You're gonna have to go right on across up there. Open that chest up more. Open up the chest more up there. Take it on, take your scissors on up there. Get the big clamp over there. You want non-verbal or verbal? No matter at this point. We need blood. Yeah.
And Foley, 2 minutes before. You're gonna get Foley catheter. With the syringe.
You're gonna need, you may need to cross clamp the aorta.
So open it all.
That will be all the way up. Come on.
Right, like that,
Clamp, open the wide.
right now on the bed right there.
No, that's new. Look at your heart. Pull, you know, expose your heart.
Chest.
Deliver the heart. Deliver the heart. Let's see, it's got blood out. It's like.
Whatever we
He's
got.
definitely got cardiac activity. Yeah, that mammary artery bleeding. Here, we'll clamp that off. But,
That aorta.
are you sure you got aorta?
I feel a pulse. You've got a pulse right now.
There's gotta be cardiac activity.
OG tube down, they filled in.
Yeah, let's make sure, yeah, put an OG down.
I can't grab my hamburger.
We got the pressure on the heart first, being on its own.
Mike, he had tracheal deviation to the left side. He had major tracheal deviation to the left. They got about 200 cc's of blood out of his, left chest. Right chest, sorry.
Like that.
Hey, Clarence.
Is there something behind it? What's that something?
Yeah.
We just don't have enough.
So that was obviously a level 1 trauma center. Those are interns that the surgeon's guiding them on how to do it. You know, putting the clamp in backwards and stuff. So this one is a gunshot victim with a massive hemothorax. I've never seen a hemothorax this big. This one's amazing. Literally fills like 800
Espacio postal abajo para hacer un túnel.
sounds
Y el
right.
soporte es
Sorry.
un espacio postal abajo.
I saw that one. What the hell? I go backwards? There it is. So after he puts the chest tube in, watch how much blood goes into the suction container. It's pretty impressive. This guy had like 800 milliliters, almost a liter of blood in his chest.
41-year-old son back to the office. He's shot in the back of his bleeding out. It's not about He's threatened to very clearly encounter the emotions. Finishing the blog is the other chief president. Dealing with all the different things that we've seen, here's one. You never know how this part of it. But a lot of those entries can be extremely serious. So you have to know and be on top of your game. Dr. DeVoe inserts a chest tube to drain the blood, filling such chest. So much blood, the original would be split or he could die. The trauma team must get Philip to surgery immediately.
Pretty impressive.
Would they have darted him first on the way to the
No,
hospital?
because he didn't have attention pneumo, he had a full blood hemo.
Okay.
Yes.
So what causes a hemothorax exactly? Is that like a puncture?
Usually you
Pleural
puncture
sac?
one of your great vessels usually,
Okay, that just leaks into the chest.
and it leaks into the chest cavity, you start hemorrhaging into it.
Okay. And then what was the last video? Was it called a thoracotomy?
Oh, a thoracotomy, yeah.
Thoracotomy, why?
That's when you just surgically open the chest and just do whatever. CPR in progress, doesn't matter, they're dead anyway.
That was performed.
So you just split the chest open, found out it was a cardiac tamponade, which we haven't gone over. That's when it's like a hemothorax, but it's in the pericardium, the sac that holds the heart. So it's pneumatic, not pneumatically, hydraulically crushing the heart.
Okay.
So they just sliced it open and let it bleed out, then the heart started beating again. Once they took the pressure off.
Why did they? Okay.
So that's the next slide, pericardial tamponade. So there's a sac that lines your heart called the pericardium. When it starts bleeding inside there, if you get a rupture of one of your surface arteries on your coronary arteries, it'll bleed in there, it'll put pressure, and the heart will actually crush itself. So it has all the same signs and symptoms of a tension pneumothorax, except lung sounds are clear and equal. So you don't have decreased lung sounds on one side. And it has what's called a narrowing pulse pressure. We're gonna go to break here in a minute after this. And what a narrowing pulse pressure, your pulse pressure is the number that is the difference between your systolic and your diastolic. So if you have a blood pressure of 120/80, your pulse pressure is 40. So the pulse pressure is narrowing, it's getting less and less every time you take the vital signs. That's a telltale sign of a pericardial tamponade, because as it's crushing the heart, the systolic and the diastolic pressures are coming together. Your systolic pressure is the heart at work, and the diastolic is at rest. So as the work and the rest are coming together, as it's getting squished, those pressures are coming together. Does that make sense? Well, it's actually more like 60/60. I think it's like this one. It'll start at 90/50, so your pulse pressure is 40. Because your next blood pressure 82/46. So now your pulse pressure is 36. Then 70/40, now your pulse pressure is 30. Then it's 52/38. Now your pulse pressure is 24. Well, every 5 minutes when you're doing it. Yeah. And they're gonna have jugular vein distension, tachycardia, hypotension. Oh, welcome back.
The heart is enclosed in a double-walled, fluid-filled sac called the pericardium. Cardiac tamponade happens when fluid accumulates abnormally in the pericardial sac, to such an extent that it compresses the heart, leading to decreased cardiac output and circulatory shock. Tamponade may develop from a hemorrhage, such as from a traumatic injury to the chest, ventricular wall rupture after a heart attack, ruptured aortic aneurysm, or a complication after heart surgery. Fluid may also accumulate as a result of other health conditions, such as infections, autoimmune diseases, kidney failure, inflammatory diseases, and cancers. The rate at which fluid is building up is often more critical than the volume of fluid. Slow accumulation of a large volume may not cause tamponade, but a relatively small effusion can do so if it builds up too rapidly, because the pericardium cannot stretch quickly enough to accommodate it. Traumatic events usually lead to faster fluid accumulation and are therefore more dangerous. Cardiac tamponade symptoms are typical of a cardiogenic shock and include chest pain, rapid heart rates, shortness of breath, and in severe cases, dizziness, fainting, and altered mental status. The skin may feel cold, sweaty, and bluish. Neck veins may appear swollen. Diagnosis is based on clinical evaluation, typically the presence of Beck's triad, hypotension, muffled heart tones, and distended neck veins. Among imaging techniques, bedside echocardiography is the preferred method to visualize and determine the size of effusion. Tamponade is...
All right. Here are your new teams. Team 1 is now Morse, Niels, Tavia, Utek, Christensen, Bailey, and Gardner. Team 2 is now Perez, J, Tompkins, Wolashuk, Friesen, Michaels, Anderson, and Friday. Group 3, Perez A, Leach, Carson, Guzman, Gross, Goss, not Gross, DeCraw, Rubis. Group 4 is Sanchez, Gamora Arroyo, Rothenberg, Caldwell, Love Creek, Coates. Go to break, be back in 5 minutes after 8. Ready to go into your brand new teams. Goss, not Gross. We used to have a medic called Gross.